difficult part is preventing that first proband itself,
Mm.
the first child with rare
Correct.
disease.
Correct.
Now it is easy to do prenatal. Once the first child is affected, they come to us, and the
The
second
second
child we
child.
can
Correct.
prevent.
Correct.
But more important is to prevent that first child from being born with that rare disease, and that can be done by doing carrier screening. So the problem with the rare diseases is multifold. First of all, because they are rare, they are not common in
Mm.
public health system, so they get very less attention
Right.
from the
No
government. They
budgets
have,
as such.
yeah,
Right.
they have other priorities. So we say there are roughly 7,000 rare diseases, because 7,000 diseases we know of.
Mm.
There are 19,500 genes in our cells,
Mm.
but we know diseases for roughly around 7,000.
Okay.
So for 7,000 diseases, averagely it takes about 7 years odyssey to find a diagnosis.
Just to understand that they have or identify that condition.
So the absence of diagnosis, the long time for diagnosis, and then the less attention and all that. So because of all these things, and because now rare diseases are gaining more importance, because all the nutritional, the
Mm.
infectious diseases are slowly getting covered, and that's when the genetic diseases become more prominent in
That
the
becomes the
society.
next in line
Correct.
priority, pretty much.
So keeping all these things in mind, and with the expertise in different fields, we started this program called as Mission Program in Pediatric Rare Genetic Disorders.
Mm.
So this is funded by Department of Biotechnology. So it's a joint collaborative program where on one side we have about 15 different institutes across the country,
Wow.
almost from right from Kashmir, Jammu up to Kerala. We have centers in almost all parts of the
And these are
country.
government institutes
These are
predominantly?
government institutes.
Right.
Some are hospitals, some are university
Mm.
labs. The basic idea is that these institutes have some facility to do some level of basic genetic testing.
Correct.
So patients with rare diseases who have not got a diagnosis after doing the basic genetic testing, they are recruited in this project.
Okay.
So the aim is to recruit about 5,000 such patients with rare diseases which are undiagnosed, and do the sequencing of exome and whole genome for these
Mm.
patients, and then try and identify either novel mutations which will help those families, more so novel genes, because as I
Mm.
said, 19,500 genes, but we know diseases only for 7,000. So
Right.
about 13,000 genes, still we don't know
Right.
what will happen if there is a mutation there.
Right.
So the aim also is to identify some of the novel genes, because then the story starts of developing diagnostics, developing therapy, whatever, once we know what's the gene causing the disease.
Right.
So on one side we have these 15 centers who recruit the patients. Then they take all the clinical data which is uploaded in an electronic form. So we made all
Like a
those.
central
Yeah.
system for
So we have
everyone.
a
Right.
registry now of a large number of patients with rare diseases. And then on our side we do their sequencing for exome or genome. And then when we come across anything novel, either a novel gene or a variant, then we have another group of basic scientists. So
Mm.
that's I think something unique about this program, that we have put together the clinical departments and the basic scientists together. So overall we are trying to make a model for a rare disease system where the recruitment of patients across different centers, get their sequencing done, generate that whole data of sequencing, and then do some functional assays to prove the gene disease association. And then as part of it we also have awareness programs where all these 14 centers are involved in increasing awareness about rare diseases across medical colleges, across schools, different platforms. And so I feel it's really a nice holistic program that Department of Biotechnology has started about 2 years back.
2 years ago.
Another 3 years are yet to go, and we hope that something really good will come out of this, or at
Right.
least the data will get generated. I am happy about that, that a lot of data is getting generated
Right.
on which further studies could be planned.
Right. Now, just correct me if I'm wrong in my understanding of this. So, you said there are centers that are recruiting patients through clinical pathways, and you have a full history of the patient's past, clinical
Yes,
past, and probably even whole genomes
yes,
of all of them as a next
yes.
step. And then you have scientists actually looking through the data in one angle, probably bioinformaticians,
Yes,
trying to identify known and novel
correct.
genes. Further to this, when you mentioned the models, right?
Yes.
Are you actually infusing those mutations into the models and then trying to discover therapy in some way?
uh, Not up to therapy, but
Right,
that's the ultimate aim.
right,
But immediate aim is to model these mutations into animal,
right.
because these rare diseases, when we find a novel gene, these are just one family.
Correct. Literally, N
So
is one.
yeah, and then we are not sure. Maybe
Right,
that's a wrong gene.
right, right.
So to be sure, now the best evidence will come from a second patient with the same mutation in the same gene,
Correct.
which is very
Rare
less
by
likely to
definition.
find
Yeah,
because these are rare.
right.
So we go down to one level evidence below, that is, make this same mutation in the homologous gene in the animal, and then see whether the same phenotype is coming.
Wow, that's
And
actually very interesting.
yeah, that gives you evidence that, or some evidence that this gene is causing this phenotype.
Yeah.
And then when we find a second mutation, we are really happy, because
Mm.
when a second patient with the same
Same
gene
mutation. Right,
mutation, same mutation or another mutation in same gene,
right,
and the phenotype is same,
right,
then we are happy that okay, we are correct. Otherwise, it's always a doubt that whether
right,
we have, because when you sequence, you will get thousands of variants,
right.
and then you pinpoint one and everything falls in place, but
Correct.
then you're not really sure that is that the gene.
Right. And for all of this to happen in the way you've described, I'm just trying to imagine the complexity, right? How many things have to go right?
Yeah,
Right?
that's right.
Like you're sequencing patient
Correct.
records, like you said, having a central database,
Yeah,
ensuring that you're not missing any matches.
yeah,
Somebody has to flag saying that, hey, the
that's right.
mutation that you're working on at a model level,
Yeah,
I've just seen it in a patient in a
correct.
completely different part of the country.
That does happen. So in this particular gene that I'm speaking about, the AIMP2 gene,
Hmm.
this in 2017 we had a family.
Okay.
Uh, so that's also quite interesting. So we had a family recruited from Delhi.
Hmm.
Uh, so this was a family with quadriparesis. That means these children had paralysis from neck down.
Hmm.
So we did exome sequencing in 2016 or something, and we found a stop codon mutation in
Hmm.
this gene called AIMP2.
Hmm.
But we were not sure, because this AIMP2 gene is really just a scaffolding protein which puts together the tRNA synthetase complex. It's a big complex.
Hmm.
This protein is just holding it together, kind of thing. So nothing was known about that gene, and we had no way of going further. And so we just kept it as such. And then, so there is one website or database called a gene matcher.
Hmm.
So gene matcher kind of helps, because how will I know if a lab in maybe US or
Correct.
UK has the same gene?
Correct.
So this website gene matcher, it helps to put people together who might have the same
Wow.
gene. So we just put in the information there and hope that somebody else also has, and they also put, and then the website links the two scientists together. So it's to
And this was
get
2017,
collaboration. Yeah, 2016
2016,
something.
2017, right?
So we were waiting, nothing was happening. We had no idea, so we just had left like that. Then suddenly one day I got one email that there is a match. Another group has found a mutation in the same gene,
Wow.
and so we went and saw, and that was a match with a patient in KMC Manipal, in Kasturba Medical College Manipal, one
So
of
an
my colleague,
Indian patient.
Indian patient only. So the one patient was from Delhi,
Right,
so that's a family in Delhi.
right,
This patient is from South India.
right.
So my friend and colleague, Dr. Girisha, their group had found this mutation, and surprisingly, it was the same mutation,
Exactly the
exact
same
same
mutation
mutation.
within the gene.
Yeah, within that same
Right.
gene, the same mutation. So we were very happy. So these
Hmm.
are two different families,
Right.
and the same mutation and the same
Same
phenotype,
condition, same
same
phenotype.
condition in the
Wow.
children. So that made us quite interested, and so we put together, we got the samples from both the families, and then we could genetically look at the
Hmm.
haplotype,
Hmm.
and looking at the haplotype, we could see these both had come from a same ancestor. They had the same
Wow.
haplotype, so
Wow.
maybe 6 7 generations back.
Wow.
That
Hmm.
was the first uh, report of that gene. And then after that, 2 3 more reports came about, and that made us really confident. And so when this project started, so one of my colleague in my institute, Dr. Rohit Joshi, So he works on fly model
Hmm.
of of different genes.
Right.
So it's called Drosophila. So then he said, okay, if you have got a gene which has
Hmm.
not been characterized,
Right.
so let me try to model it in fly. So then he took that gene and they deleted that gene using CRISPR-Cas9 technique.
Right.
And so physically they could not see because this
Of
was
course.
paralysis. So
Right.
physically the head size, the fly
Right.
was
Of course.
okay. But then when they looked at the fly behavior, so
Hmm.
there are various tests of fly behavior.
Hmm.
So one thing is the fluttering of the wings.
Hmm.
So if they fix the fly on a needle, the flies are very small, the fruit
Correct.
flies,
Correct.
and then they give a puff of air, the flies start fluttering. They
Right.
flutter their wings so fast that you can't see those wings. It's
Oh,
so
wow.
fast.
Right.
And whereas the mutant fly now was fluttering its wings so slowly that you could really see the wings. So
Wow.
that was one experiment they did. Then another experiment, they put those flies in a test tube, and these flies have a tendency to move upwards.
Hmm.
So from the test tube. So when you shake the test tube, they all move upwards.
Hmm.
So the control flies were all moving upwards, but these flies would not cross beyond the 50% of the tube.
Wow.
So for us, it was very satisfying kind of to see the story starting from
Yeah.
patient to finding
Right.
the gene to then modeling it
Right.
in a fly. That kind of completes the story.
Right.
And then now we have had multiple reports of mutation in this same gene.
Hmm.
So it's
Over
now
the
well
last five,
established
6 years now.
over
Right.
last 5 years. Now it's established that that's the gene responsible for that phenotype. Now
Wow.
that would open up some avenues for doing maybe further research too. First of all, it really helps in doing prenatal diagnosis because now
Exactly. That's what
we
I
know
was
the
thinking. Right.
gene. The first low hanging fruit is prenatal diagnosis.
Right.
So
At
we
least
can
use it in a everyday clinical use case that way.
correct
Right.
to prevent birth of another child if there
Right.
is a mutation in that
Right.
gene. Therapy is something which takes time and we don't know
Probably
how much it will be
decades
useful. Yeah.
even. Right. And also it's a choice, right? Like it really, you would
Yeah.
put all your uh, knowledge and will and resource towards something that you can quickly create impact on.
Correct.
There again, unfortunately, you'll have to pick. If two rare diseases are there, you'll
Yeah.
end up picking slightly more popular rare disease
That's right.
for which you will put the
Yeah.
therapy work. But you're right, sir. At least the first thing you can do as a researcher, clinician, practicing doctor, you will be the first one to actually know that, okay, these genes I want to look at, especially in the prenatal,
That's
at least prevention in some way,
that's right.
in a very different aspect.
Yeah.
Now, talking about that, I think CDFD has started prenatal diagnostics in what year roughly?
We have been doing since CDFD began. So,
Began. Okay.
so the prenatal diagnostics has two components. One is taking the sample,
Right.
and second is doing the test.
Right.
So, doing the test happens in CDFD, but
Right.
taking the sample, that is
Of
either
course.
amniocentesis or chorionic villus sampling, that would happen in any of the clinics.
Mm.
So, CDFD has a MOU with this Nizam's Institute of Medical Sciences. So, we have
Right.
established a department of medical genetics there.
Right.
So, all the prenatal diagnosis procedures are done there
Right.
using ultrasound guidance. Those samples come to us, and then so we can do prenatal for any disease where the first patient is known to have the disease.
Mm.
So we call it the proband. So
Right.
once proband has any disease, we can look at the same in the prenatal.
Got
But
it.
that's the easier part. The more difficult part is preventing that first proband itself,
Mm.
the first child with rare
Correct.
disease.
Correct.
Now it is easy to do prenatal. Once the first child is affected, they come to us, and
For
the
the
second
second
child we
child.
can
Correct.
prevent.
Correct.
But more important is to prevent that first child from being born with
Mm.
that rare disease, and that can be done by doing carrier screening. So we can screen couples before they plan for a pregnancy
Mm.
for different diseases. Now that at present we are recommending it to be done for some of the commoner rare diseases like thalassemia and
Right.
spinal muscular atrophy.
Right.
But for other genome wide rare diseases, as a routine, we don't advise everyone to go through because a lot of unknowns are there.
Correct.
We still don't know which gene will cause which disease,
Mm.
how severe it will be, and all. So, we do the carrier screening for all the genes only in specific families where there is consanguinity or where there is some
Mm.
family history and all. Then we can check all their genes and see if they are likely to have a disease. So, that way we can try to prevent the first child itself.
Right. Another thing is, sir, when you were talking about it, I was just thinking, what happens to people who have no idea about any of these conditions? or probably even carrying some carrier mutations, but probably nobody ever told them. So what's changing there? Like, are gynecologists advising, are doctors advising? So what's changing in
Yeah, so that's that's really the dichotomy that we have. So we
right,
have institutes in India who are
right,
doing high-end
right.
research and high-end services, especially in the cities. And then we have smaller institutes where really still nothing is happening.
Hmm.
So that awareness has to increase. It is increasing slowly because the patient does not come first to a genetics
Obviously,
department.
probably they don't even know something
Yeah,
like a genetic counselor exists.
they never
Yeah,
expect.
right.
Couple takes a risk of about 2 to 3%,
Mm.
which nobody thinks of. But there is a population risk of 2 to 3% that every couple takes this risk. If 100 couples get pregnant and have a child, 2 to 3 of them will have some abnormality.
That is still a big
Yeah, but
percentage.
that percentage is same whether it is in Africa, America,
Wow.
US or India.
And
That's
India population is much bigger.
yeah,
The 2-3% of Indian population is a very
it's
very
huge.
big
Yeah.
number.
So, but that's the risk everybody takes without thinking. So that's why like no one goes what we call it as pre-conception clinics. So it's
That doesn't
post,
exist today.
yeah. So it's
Okay.
post
Right.
marriage and
Right.
pre-pregnancy.
Right.
That's
Right.
the best time
Ideal. Right.
ideal for people to go and consult. Many of the couples in the high tech city and all
Mm.
who are more aware,
Right.
they do come to us in that particular time. And that time we can take their family history and
Mm.
advise them about what carrier screening and all. But on the other hand, we have the at the grassroots level we have very less
Of course.
awareness, and then that's where that 7 year odyssey comes of patient
Mm.
being diagnosed. But slowly this awareness is improving. The pediatricians and obstetricians, they are the ones who
Mm.
first see these patients, and then slowly they are starting to channelize these patients to genetic centers. We have even tier 2 cities now, we have a lot of genetics. So when genetics began, it was only medical genetics, only one center was there in Sanjay Gandhi Postgraduate Institute
Mm.
in Lucknow.
And
But
you graduated
yeah,
from
I
there. Right.
graduated from there.
Right.
Now there are more than 7 centers from where training is happening.
Mm.
And especially now with the private sector coming into the diagnostics, it has really exploded. Now these diagnostics are available even to smaller places.
Mm.
So what is lacking now is awareness. It's
Right.
not the availability, because the private labs have collection centers across,
They'll go
even smaller,
wherever
yeah,
and
wherever
collect.
they are
Right.
there.
Right.
But the doctor has to advise for it or at
Correct.
least pick up. That is happening little slowly, but it's much better than what was before.
So talking about national uh, level awareness, right? Most recent news, we are being bombarded by this, especially our community. We are getting it back from our friends and colleagues from different industries, which is Prime Minister Modi's announcement about the genomic data being out there.
Yeah,
For us who've been inside this, we see it a bit differently, and for common public it's a very new thing. So
yeah,
what's your take on that? What does that have? What kind of impact do you think will that have on general public awareness?
yeah. So first we should go into why there was a need to make this
Mm.
database. So it all begins from knowing what we call variations. So if you look at our genome, we are 99% same to chimpanzee genome.
Mm.
Okay, so
Right.
there's a little bit of monkey in all of us.
Right.
We are 99.9% same among each other. So
Mm.
all humans on this earth have 99.9% genome same.
Mm.
It's 0.1% difference that makes us all different from each
Mm.
other. But it is 0.1% of 3 billion. So there are 3 billion bases,
This
and
right.
so 0.1% different makes up to almost 3 million. That is
Mm.
30 lakh places we are different from each other.
Mm.
So although it is 0.1%, it's still a huge
Still a big
number.
number, right?
Most of these variations we call them as polymorphisms. So they are differences among individuals, but they don't cause a disease.
Mm.
So we distinguish them from a pathogenic variant. We call
Right.
them as benign variants.
Right.
They are something which make us all different from each other,
Mm.
but they don't cause a disease. Now, the problem is that these polymorphisms are different frequency in different populations.
Mm.
So, if you look at the 30 lakh which are there in the US population, they would be different from those in the Asian population and different in the African.
Mm.
So, now when we do any sort of genomic study, whether it is a exome sequencing or genome sequencing, what we do is that we exclude those normal variants so that we get the disease causing
Correct.
variant. So if you do something like a genome sequencing in a Caucasian individual and you exclude all the variants which are present in Caucasian population,
Hmm.
then you end up getting a small list of variants which you have to see which one is disease causing.
Right.
But if you use the Caucasian database to filter the Indian patient,
Hmm.
you will be left with a large number of variants
Right.
because the Indian variants are not included in the
Correct.
Caucasian database. And the problem is that till now we have large number of these normal population databases, either 1000 genome or the Nomad. Nomad has more than 8 lakh normal, so-called normal or self-proclaimed normal
Right.
individuals
Right.
whose database is there. But most of them are Caucasian. There are very
Right.
few Indians there. And so the problem happens when you want to analyze this exome or genome data, then a large number of variants remain through which you have to go through. Whereas in a
Right.
Caucasian population now, it's much easier to analyze this exome and genome data. So there was a need felt for having a local, ethnically separate population database.
Hmm.
So that was the genesis. And this I am talking only from the point of view of genetic diseases or the single gene disorders.
Right.
The same applies to another huge field called as pharmacogenetics.
Correct.
So pharmacogenetics is the field where you look for variations in our genome, those 30 lakh which are different. They decide how you will respond to a particular drug. So if the same drug is given to 100 people, some respond, some don't respond. We did not know why earlier.
Right.
Now we know that there are these changes which make us respond differently. And if we know that from beforehand, then we can either give a lower dose to avoid some side effects, or very severe side effects, don't give that drug to that individual.
Hmm.
And that way, every drug prescribing in future is going to be after a genetic testing.
Hmm.
And now to know that particular variation which causes this difference, again we need a Indian
Reference.
population reference.
Right.
So this Genome India project was launched in 2020.
Hmm.
So before that we did not have any database local. So then small databases were being created by multiple people. We ourselves created a 1500 exome database just to make our life easier, because
Right.
we were dealing with exomes but we were
Right.
having this difficulty. So we made that in 2021, but that was just some 1500 exomes. But what we needed are
Whole
genomes,
genomes.
and that's a big undertaking also. A lot of funds also needed for
Right.
that. So 2020 the Department of Biotechnology had launched this project. Because of COVID it got little
Oh.
extended, because
Right.
that is the same
Of
time when
course.
COVID started.
Correct. Correct.
And so the 10,000 now, so here again there was a question, whom do you call Indian? Because we have so many different
Right.
people from different ethnic groups. We have, earlier they used to classify them based on the haplotypes as Tibeto-Bourbon, Aryan, Dravidian, based on the polymorphisms
Hmm.
through the haplotype. So now we had to include at least few patients from each of these bigger populations.
Even within the
So
context
yeah,
of India.
so
Right.
within India, India itself is a mixture of so many
Right.
populations. So based on those earlier studies, which so many of these human geneticists have done, like Dr. Tangaraj's group and all. So we had this idea about groups of populations. So then conscious effort was made to make sure to get proportional, depending on the size of the group, a proportional number in that 10,000 was included. Now
Hmm.
10,000 actually is a very small
Small
number.
number.
As
Right.
I said, 8 lakh
Right.
database is there. For
Right.
India, 150 crore population,
Hmm.
10,000 is very small, but that was the number which was thought to be doable based
Hmm.
on the funds needed.
Right.
And so these all populations were put together. 22 institutes were involved in this
Hmm.
project. And so many of these institutes were involved in gathering, because we had to now go to the population. These are not patients.
Correct.
So we needed normal
Normal.
volunteers,
Right.
so called people who did not have maybe diabetes, hypertension or something in their 20s, 30s.
Hmm.
And so they were going to these different places, like maybe villages, where they would contact different ways people.
Wow.
They had to contact, because some of these populations are very rare, tribal populations
Hmm.
and all.
And they
So
wouldn't
lots
even
of
find the need to go to hospital because they're
that's
healthy.
right, they are
So,
healthy. So
right.
getting healthy people to voluntarily give a blood sample and all, it's little difficult. And
Right.
since it's a research project in India, we don't have the system of giving them cash or something. So
Hmm.
it has to be voluntary.
Right.
So finding volunteers, and that too from all this population, it took some time. Then these samples were collected, and 2,500 each were sequenced in 4 different centers. So we had
Right.
in CCMB in Hyderabad, we had NIBMG in Calcutta, and we had IGIB in New Delhi, and in Bangalore we had the Center for Brain Research.
Right,
So
CBR.
these four places, 2,500 each, which these people were sequenced, and that database now has been, so since it is made from government money, it is now open for
Open.
anyone to use
Right,
with some riders, because you have to have some MOU kind of a thing.
right.
So now you can request for that data. So that is what on 9 January last month this was released by Prime Minister of India, and that is a beginning where probably now it will be much more easier to analyze the data what is available. And so now Department of Biotechnology has given out a call for proposal to develop research proposals using this data.
Wow.
So that's a logical
Next step.
sequential thing, the
Right.
next step. And I hope as more data gets generated, like even in our mission program project, whatever data is getting generated, it all gets deposited in one repository called as IBDC, so Indian Biological Data
Which is the
Center.
same thing where the
The
10,000 genomes also
correct.
reside,
So
right?
the 10,000 genomes reside there. Our project, all COVID sequencing,
COVID
what was done,
sequenced project,
everything
right?
research there in the INSACOG project. So this is a big repository of data. So actually now any project funded by Department of Biotechnology, the raw data has to be submitted there. So that's
Right.
mandatory.
In this topic, you mentioned pharmacogenetics, which in a way also is popular as personalized medicine, personalized therapy, and it leads into that entire world where you said something very interesting. You said in the future, drugs will only be prescribed after a genetic test is a report is available. Can we talk about that eventual future? Like, where do you see that going today? Where is it, and how far do you
Yeah.
think it will?
It's not really a new concept. We used to do this same kind of not really testing, but like G6PD deficiency, glucose 6 phosphate deficiency. This is a very common kind of condition that is there, especially in Punjab population. It's very
Oh.
high. Okay, this does not cause any disease. But if a patient has G6PD deficiency, and if you give him the chloroquine tablet, which is given
Chloroquine
in
on malaria. Right.
malaria,
Right.
then he will get or the primaquine, especially maybe the primaquine what we used to give in the Vivex type of malaria, then that patient will have severe hemolysis. His blood cells will start breaking, and he'll end up with renal failure. So with kidney failure, the
Wow.
patient he will get better from malaria, but he'll get kidney failure.
Wow.
So as a routine, we always used to do the G6PD deficiency testing, which was not a genetic test. So this concept was there in
It's
medicine
more like a
earlier.
protein
Yeah, it's a protein. So it was
check,
like an enzyme assay we would
ELISA
do,
or something like that.
ELISA kind
Right.
of thing. And this was done even before. So at present, what happens? The disease symptoms come, you give a drug, it doesn't work, you change the drug, it doesn't work, you change the drug.
By then it's too
So
late
yeah,
sometimes.
so the patient is in disease for a long time.
Mm.
By personalized medicine, what we want to do is that if the symptoms are there, you do a test and find out whether he'll respond to this drug or not, and give that right drug so that he's in disease for less time.
Right. And NHM today spends money on few cancers, especially oral, breast, and cervical, in some sort of a
Mhm.
screening and
Hmm.
therapy management. Of course, TB, we all understand a lot of effort
Yeah,
is happening and testing is happening, and Indian companies have done quite well,
yeah,
even offering the tests
yeah.
as a system. Uh, do you think NHM or something else will start getting into screening like this at some
Yeah,
point?
like NHM also doesn't have separate funds allocated, but in some states they had done some amount of newborn screening. See, newborn screening is something in 1965s or 70s it started in US with the first newborn
Wow.
screening test
Right.
being developed,
Right.
and now they test for more than 40-50 disorders in every baby who is born. In
By default.
India, yeah, in India we don't have except two states, Goa and Kerala.
Hmm.
These two states are the ones who have started.
Right.
But nationwide newborn screening would be something as the first step that is needed. So
Correct.
if you are able to screen, and that too we need even for the 5 common disorders if we screen.
Right.
So antenatal screening for 2 or 3 diseases and newborn screening for 5 diseases, it can take down the load of many of the genetic diseases to a large extent. But the amounts involved are huge
Hmm.
because our population is so high.
Hmm.
So for government to take up this, we hope in the nearest future. Now, before the rare disease policy, there was nothing for
Correct.
rare diseases. Now the rare disease policy 2021, it speaks about all these things, about
Mm.
improving diagnostics. And so I feel at some point probably we'll be going for having a nationwide newborn screening and antenatal screening, because the whole networks exists.
Correct.
The nationwide
Capability
immunization
exists,
happens.
right?
So all the babies get immunized right from their birth up to about 5 years
Mm.
at regular intervals.
Mm.
The same system could help in doing this. There are different programs that are working towards it. So there's one program called as DBT Ummeed,
Mm.
Department of Biotechnology. They have a Ummeed program, Unique Methods in Management of Inherited
Oh,
Disorders.
wow.
So under this program, they are funding for development of genetic testing laboratories at small medical colleges. So
And these
in
are
the
government
this
or
is a Department of
right,
Biotechnology, so Ministry
right,
of Science and Technology in government
right,
medical colleges.
right.
So in the first phase, they had 7 such centers established. In the second phase, now 30 more centers are being
Wow.
established. So small medical colleges they are starting. And another program under that, what they have is called as aspirational district program.
Mm.
So government of India has identified 115 districts as aspirational districts.
Mm.
These districts need a lot of uplifting
Right.
because they are not yet up to the mark. So in these aspirational districts, now we are at district hospital level, we are doing the screening, the newborn screening and
Mm.
the antenatal screening for thalassemia,
Right.
so that this awareness and this facility gets established. And so 30 new aspirational districts have been funded now, and in the long run, about all the 100 districts in the next 2-3 years, they would be added.
And these are spread across
So
the country and
yeah, across the
like
country, these have
across
been
states.
identified by Niti Aayog,
Right.
and so there are different ways in which things are happening. As India is a big country, you can't
Yeah.
suddenly have a big program going
Correct.
on, but slowly these all will build up towards
Right.
probably
I mean, I'm like I said, I'm very happy hearing about these things because there is no easy way to find out that all of this is happening. And it's happening at research level, academic level, policy level.
Yeah.
And it's a big country with a lot of things happening at the same time. Not everything comes to news in the same way, not everything comes out at the same time. But I'm again very happy that I got to spend time with you today and hear about all these things. I'm very happy you managed to come. You made some time today.
Yeah.
And yeah, I mean, this has been great. Thank you so much.